He is a professor and director of medical physics in Department of Radiation Oncology, University of Minnesota. So, Dr. Parham, you can start with your presentation, please.
Okay, good afternoon, everyone. Thank you, Asad, for the invitation. And let me share my screen here.
Thank you very much.
Can you all hear me well?
Yes, we can hear you.
Okay, great. So, we're going to change focus right now. I just listened to two great presentations on the implementation of the cone-beam CT at image guidance, I guess, at the Aga Khan University, and also the perspective of the physicians on the IGRT, the value of IGRT, and the acceptance of margins, and so on and so forth. So at this point, I'm switching focus and to the image-guided patient therapy and focus on the more of the what imaging dose we have or we encountered, and the QA, we have to discuss the QA. I'm going to focus mostly on the cone-beam CT, kilovoltage cone-beam CT, because as you know, that's the most common IGRT modality being utilized these days. So I have nothing to disclose. I do have references to many commercial products, and that does not imply endorsement of any of them. So outline of the presentation, I'm going to do a brief review of the current IGRT devices and techniques, review the imaging dose or the magnitude of imaging dose from X-ray based IGRT systems, and also look at a few recommendations on the reduction or optimization of imaging dose and other factors involved. And then that last section will be on the QA of the X-ray based IGRT systems, and then a summary. So current IGRT devices and techniques, as you are probably aware, there's quite a few of them out there, and the list actually grows by the year. So I have a number of them listed here on the left-hand side. Let me see if I can get my pointer in here. There you go. So on the left-hand side is a 2D acquisition devices. I mean, electronic portal imaging devices have been around for a long time. Almost all Linux have it these days. There is gantry mounted KV digital radiography. Any CRM Linux with the cone-beam CT capabilities does have a 2D KV imaging capabilities. There is a room mounted KV imaging like a CyberKnife and ExactTrack, and those are have been used for quite a few years, and they are often used for interfraction and intrafraction motion management or patient motion management as well. Right-hand side is a 3D acquisition ones. Kilovoltage cone-beam, I mentioned, that's the most common. All the CRM Linux have it, Gamma Knife Icon, Varian, Halcyon, and some other specialty units have those. Kilovoltage CT, CT on rail is the one that has been around for a while. There is a RadExact, which is an old tomotherapy unit. It does have kilovoltage CT and the newer ones. And there is a latest entry is a reflection, which is a PET guided therapy, and that utilizes kilovoltage CT. And then megavoltage cone-beam, Varian Halcyon has its Siemens Linux. I don't believe there are many of them left because Siemens ceased production a number of years ago. So there's a few of those out there, but not a whole lot. And the megavoltage CT, which is basically used in tomotherapy or RadExact units. And again, kilovoltage cone-beam CT is the most commonly used. I make the focus of this is mostly on kilovoltage cone-beam. I do mention a couple of these, like room-mounted KV, like CyberKnife and the BrainLab. Again, these are room-mounted, they're not gantry-mounted, and the X-ray tube and imaging panel, and they are opposite directions of each other. And these are mostly used for the stereotactic applications and to monitor intrafraction movement. And the newer ones, of course, have the LED markers and the motion management devices other than X-ray, and it's a combination modality device these days. Kilovoltage comb CT, you mentioned variant TrueBeam that you have in Aga Khan University. Of course, there's Elekta. There is this stereotactic device, Elekta Icon. The new ones have a comb beam CT, and then there's some device that you can sell and attach to any Linux that you may have, or actually in Proton centers use that too. This called is imaging. There is more than one manufacturer of them. And then again, CT and megavoltage CT and CBCT, again, rad-exact tomotherapy. The tomotherapy traditionally had a 3.5 MV flattening filter-free beam for imaging, and the new ones have kilovoltage as well. The variant Halcyon is a 6 MV triple F beam, which is this one, and then the Siemens Linux, they had two different imaging beam energies, 6 MV and a 4 MV, but again, they are not built anymore. And the kilovoltage CT, again, CT on rail, traditionally being used mostly in the Proton centers. IGRT rad-exact added a kilovoltage tube to the new ones, and this kilovoltage tube is enabling the image guidance to be done with megavoltage or kilovoltage, so which is actually a major improvement to the older tomotherapy units that we can only use the megavoltage CT on them. And then I mentioned the Reflection X1, which is a combination LINAC PET and kilovoltage CT. It has been installed. I believe there are at least 3 of them installed in the US. I'm not sure about abroad. The PET part is not being used yet. It's not FDA approved, I believe, but the kilovoltage is being utilized. So they use that for patient treatments. So, and then non-X-ray based imaging, the focus of the talk is on the, again, X-ray based ones, but there's quite a few of them out there. Ultrasound guidance, MR guidance, you're very well aware of those, and those are the ones that are used mostly for adaptation, for adaptive planning, and they can account for the intrafraction motion very well. And then there's the surface guidance. There are 3 devices out there right now, and these are becoming more popular, at least in the US. I know part of Europe, they use it quite a bit, and oftentimes we utilize them in combination with X-ray based imaging systems. So we have is a multimodality imaging type of patient motion. So I have a question in here. Asad asked me to put some questions in the slides.
I will run the Zoom poll.
Go ahead, please. Yeah, it's a quick quiz way in the beginning. So, and if you make a mistake, don't worry about it. There's nothing wrong with making mistakes.
Okay, participants are requested to answer the question.
Sure. Yeah, so the question is, comb beam CT using KV X-rays was made possible 1A, adding floor or ceiling mounted KV X-ray tubes to the room. B, adding a KV X-ray tube to the drum assembly of a LINAC at 90 degree to megavoltage beam axis. C, attaching a kilovoltage X-ray tube at 135 degrees to megavoltage beam axis. Or D, installing a CT on rail in the treatment room. So okay, so we have 11 answers, and there are more answers coming in. So should I wait a bit longer, Asad?
Yeah, just ending the poll. So sure. We have 86% have given answer of B, okay. And some of them answer the C and D.
Sure. Okay. All right. So the correct answer is C, B, and I have a reference for that here. This is actually the I would say it may be the first paper published on comb beam CT by David Jeffrey. And again, KV X-ray tube was added to the drum assembly or the gantry of a LINAC at 90 degrees. Answer A is essentially brain lab or CyberKnife. D is just a regular CT scanner, and C is I don't have a slide of that in this presentation, but it was one of the first attempts to get a KV imaging on a LINAC was attaching a tube at 135 degrees to the MV beam axis, and there's a picture of that, which I don't have it in here. but B is the correct answer. Okay, moving on to the main focus of one of the main focus of the talk, the imaging dose from X-ray based IGRT system. So we know that we use the image guidance. We've been using it for 20 plus years in the form that we call it these days, essentially daily IGRT. And the question came about I don't know, about 20 years ago, is the imaging dose of concern? So the answer to that is maybe. For the most part, the magnitude of imaging dose is negligible. Especially, we treat a patient, these are cancer patients, we treat them to 50, 60, 70 gray. So the imaging dose magnitude, if you compare that to the therapeutic dose, is negligible. But it may become significant if the frequency of imaging is high. If the patient is imaged 2 or 3 times for adjustment, for the position adjustment, and so on and so forth. If the megavoltage imaging is used, the dose from those has traditionally been higher. And there's a special concern for pediatric patients, because as you know, again, they're going to live a long life, and the concern here is for the long-term carcinogenic effects and so on the pediatric cases. So it has been a more focus on limiting the imaging dose for the pediatric cases. And then you have to keep in mind, image volume is almost always larger than the treated one. So more of the healthy tissue, which is spared as part of a radiation therapy, is exposed to imaging dose, albeit it may not be high magnitude. So that prompted, at least in the US, it led to 2 different task group reports, TG175, which is an older one, 2007, and TG180 was published 2018, and they focus on imaging dose on from IGRT. And the following slides I have, some of them are actually recommendations from task group 180. So what affects the imaging dose? There's a whole list of items. The beam quality, kilovoltage versus megavoltage. Again, frequency of imaging. Whether we do planar, means 2D imaging, or volumetric or 3D imaging. Patient size matters, and you see it later on, and is more important for kilovoltage imaging. If somebody does megavoltage imaging, like the old Siemens units, the number of MUs delivered mattered quite a bit. When you look at kV imaging, the technique used, the current time product, and kilovoltage, and filtration, they all affect the dose. When it comes to helical tomotherapy, like the Radixact, then kilovoltage and ME, both of them, the pitch matters, it affects the dose. And the other factors, the imaging field size, how long you do it, craniocaudally, the arc start angles, and so on and so forth, which is a CBCT specific. So I have this slide, which is I always show is somebody asked me, okay, what is the magnitude of imaging dose from different modalities? So I put this slide together. Again, this is just an estimate. It's not a really patient dose, and many factors affect this. But if you look at it just as an outline or outline of what the imaging dose would be, megavoltage portal imaging, this is what we traditionally have been doing, like a orthogonal pair imaging. About 4 centigrade, we estimate that to be. Kilovoltage digital radiography, this is the kV that you use, like a 2D kV that you use your LINAC for. That has very low dose, much less than 1 centigrade per image pair. The room-mounted kV, like the CyberKnife and the Exact Track, they are, again, very low dose. Keep in mind, they are used a lot. So you may actually have hundreds of images done. And the megavoltage cone beam, if 1 to 12 centigrade, depending on the MU delivered, megavoltage CT, which is a tomotherapy, 1 to 4 centigrade per scan. And the kilovoltage cone beam is a range, but fraction of the centigrade to 4, depending on the protocol use, and kilovoltage CT, which is the tomo, the new tomo, again, 1 to 4 centigrade. So I just have a question that where are these images? Let me look at the question. This is the dose for whole image area and what depth. The dose, this is like a average dose. There is a variation, as you can see. There is a variation with depth, with patient and all that. So this is just a general guideline. Like if somebody is wondering what is the kilovoltage cone beam for a pelvis scan, if a physician asks me that, I say, well, it's about 3 to 4 centigrade. So again, is it just a guideline and it's a ballpark value. Again, kilovoltage cone beam, I highlight it here. It is a wide range of kilovoltage cone beam imaging dose. Now, focusing on kilovoltage cone beam, the factors that affect this, the tube current, the higher current you run through the tube, this is very it's obvious, right? The higher the current, the higher the dose. That's a linear relationship. The higher is the kilovoltage, it's a higher dose, and the relationship is kVp squared. Bow tie filter, most of the new systems have bow tie filter, and bow tie filter, it does bring down the loss usually. The arc start-stop angle, I have a slide on this. It does affect what organs at risk get an imaging dose. And the cassette size, the blade setting is for variant units, cassette size is for Elekta units. And again, this affects the imaging volume. And of course, the patient size, the smaller the patient, the higher the organ dose. And I have a slide on all of this coming up. So tube current, this is a measurement actually we did in-house using the Elekta unit many years ago. And we just essentially delivered the same number of frames to a solid water phantom. We measured the dose at 1 cm depth. And again, this is obvious that if the milliamp second goes higher, the dose has to go higher. Keep in mind, this is exaggerated. The actual dose to patients, if you do a trunk imaging on an Elekta unit, usually we're in this region, somewhere in here. For head and neck is way down there because it uses a lot lower milliamp seconds. Kilovoltage, based on measurements, going from 100 to 120 kVp, about 60% dose increase. This is almost similar to what I found in the classic diagnostic radiology textbook, physics of radiology textbook, Christensen's, and it says the intensity of that is proportional to kVp square. So again, if you use higher kVp, you get higher dose, and it usually varies by about a factor of kVp square. Bow tie filter, and the older units did not have bow tie filter. All of the new ones do have it. They are there to spare the skin more and to reduce the dose. Keep that in mind. If you look at the protocols on any cone beam CT system, the bow tie filter, if there is a bow tie filter protocol and a non-bow tie filter one, usually the one with the bow tie filter has higher tube current. So when I say bow tie filter reduces imaging dose, is assuming that you're keeping the MAS the same. Inherent filtration, some of the newer KV tubes have added filtration, reducing imaging dose. The case in point is a variant Linux. The variant had the older OBI unit in the C series Linux, and when they switched from the OBI to the what they call XI on the true beams, they actually added additional filtration, so that reduced the imaging dose. And then this last one, additional filtration, this was some attempt by a few to add, actually manually add filters. This is not a routine thing to be used, and I was just a study published, but obviously if you add filter, you could lower the dose, but you may lose the image quality as well, potentially. The arc start-stop angles, this is applicable mostly to the partial arc imaging. Obviously affects the image volume depending on where you start and stop. The organs at risk in that pathway would get dose, and the ones that are not in that get less dose. And the blade setting and cassette size, again, this matters mostly in the craniocaudally or in and out position, how much of the patient's volume you're going to image. So this is a study done on the dose variation with patient size. So this was a calculation done for a number of pelvic patients, and we actually look at the bladder, rectum, and isocenter and maximum dose of the patient. We try to correlate that with the body mass index, which is a measure of essentially used here in the US, at least, for the determination of the, again, the patient size, let's say. So the higher the BMI is, the lower the internal organ doses are. And the reason for that is if you have a patient who is actually larger, you're using the same technique to image that patient. So the absorbed dose to the organs internal to the body, like the bladder and rectum, I mean, if it's a male patient, the prostate, those will be less than a patient who is thin as a lower weight. The maximum dose is the same. And the reason for that is you use the same technique essentially, but patients are different sizes. There is no adjustment of the output of a unit. Now, if you extrapolate this to the left, to the right, sorry, to the right, and you get lower dose. If you go to the left and lower BMI, let's say pediatric cases, they would fall somewhere in here. So if you use the same imaging protocol for a pediatric patient, you could actually get you will give more dose to that pediatric patient if you use the adult imaging protocol. And you have a slide on that coming up. So imaging dose reduction, some of these are recommendations at TG180, some of them are of other sources. So is it warranted to reduce a dose? It is if the dose burden on the organs at risk is high. If, again, you have a pediatric patient, you have some electronic device, and there are suggestions for doing that. So looking at the left, again, double exposure portal imaging, limiting collimator size. We often do this if we have a patient with a pacemaker, for example. We don't want to expose the pacemaker to the imaging dose, so we actually limit the collimator size for that purpose. Mega voltage cone beam, again, that's old Siemens units that lower MU resulted in lower dose. Mega voltage CT, this is a tomotherapy unit, coarse mode, reduced dose quite a bit. And again, if you use KV instead of MV, you get lower dose. And on the right-hand side, these are mostly, I believe these are mostly the kilovoltage cone beam, yes. So these are the lower dose protocol, lower MAS and KVP that lowers the dose, reducing the scan length I mentioned before. Number of projections does affect it linearly, and the gantry rotation angles. So all of these affect the imaging dose. Now keep in mind, if you reduce the imaging dose, we need to have a good quality image. So if the image quality is not good and you repeat the imaging because of that, then you defeat the purpose. You actually expose the patient to more dose. Example of lower dose protocol. This is for pediatric case. This is an actual patient that we had. And we essentially calculated the dose to that pediatric patient. On the top is if we use the pelvis abdomen protocol on an electrolinac. This is 120 kbp and 1 MAS. This is a dose that the patient would get. I think this was probably 11 imaging sessions. So you could give up to about 40 to 45 centigrade imaging dose to this patient. Now, for pediatric patients, we don't use the adult protocol. We use actually the head and neck protocol, which is much lower, 100 kbp, 0.1 MAS. And the dose to that pediatric patient from imaging for 11 sessions was reduced to about 2 centigrade max. And again, so it was an 18-fold decrease in the dose just by using a lower imaging protocol. And the image quality was fine for this. This is, again, is a pediatric case, it's a small body size, and there's no need to use adult protocols for it. So the reason for this is because there's a large variation in these units. So this is an example of the Elekta XDI. I don't think they've changed a whole lot with the Versa units, but these are all the different imaging protocols that comes with the unit, going from fast head and neck, which is the lowest dose, to prostate M10, which is the highest dose. And these are measured at the ISO center for a single fraction. These are not patient doses. This is just, I'm presenting this as a relative measure of how the imaging dose varies by protocol usage. So if you go from lowest to highest, there is a 76-fold increase in imaging dose between the lowest dose protocol and the highest one. So there is a significant difference in the dose delivered from the unit with different protocols. Same thing for the variant. This wasn't on the variant true beam, again with the clinical protocols, and again, a 67-fold increase in the dose going from the image gently to pelvis obese, which is the highest dose one. So always keep this in mind, and we always do actually ourselves, especially for pediatric patients, occasionally for the smaller patients. We don't have to use a high dose protocol. Scan length. This is a Monte Carlo study published by Spezia et al. In 2012. It demonstrates that if you use the S20 cassette on Elekta versus S10, again, the difference between these is in the in and out section, in the craniocaudal direction, is narrower beam essentially. So if you do on the left-hand side is a sagittal plane color wash pelvis, chest, and head and neck, top to bottom. On the right-hand side is the same thing with the S10. And you can see obviously the imaging dose, this volume of tissue like here and here is not exposed to the imaging dose because of the using the smaller scan length. Number of projections, again, this was what we did, and what we did, actually, this is simulation or other calculation. What we did, we dropped the number of projections. I don't recall, this was an old Elekta unit. I don't recall how many projections it was. These could be 600 or 700 projections for a full 360-degree rotation. But essentially, if you cut that by half, you get half the dose to the patient. Again, keeping in mind if the image quality is good for patient positioning. And then gantry angle, this was published by Ding et al. In 2010. Again, this is a partial arc head and neck. On the right-hand side is when the gantry rotates in the anterior of the patient. Again, this is an organ doses you get, left or right eye. Core doesn't matter a whole lot because core is more central. But if they change the gantry start-stop angle and rotate in the back, essentially, posterior of the patient, you cut down the dose of the eye by quite a bit. Again, the magnitude is not that high. This is just for demonstration purposes. Peripheral dose. So we all know about peripheral dose. We all know about the leakage from the LINAC, the scatter radiation and all that. Now, so the definition of peripheral dose is basically dose outside the treated volume of the patient. So a scatter and leakage contribute to that. Imaging dose does as well. It is of interest when, again, organ at risk, implanted electronic device, patient previously treated, the organ at risk is at a critical dose juncture and all that. And image volume may be larger than treated volume, and that is correct for most cases, not all. There will be several studies on this to look at the magnitude of peripheral dose. I list 3 of them in here. The one from Prex et al. 2008 conclude that the KB, CBCT peripheral dose is the same order of magnitude as that from IMRT. The one by Kui et al. Again, this is the same order of magnitude that of a LINAC leakage. And then the other one from GIA, megavoltage to kilovoltage is the same. So the bottom line is the magnitude of peripheral dose is very similar to that we'll get from the leakage, from the head leakage from a LINAC or from a scatter. So it's not higher, but it adds to what you had before. So basically you double or triple your peripheral dose to the patient. And when it comes to the I mentioned treated volume, this is an actual patient plan. On the left is a, let me see, 1, 2, 3, 4, is a 7-field IMRT plan. And if I put a treated volume on this mustard color line is effectively where we treated the patient. So this is our treated volume. If we image this patient with a XVI unit, M20 again, the image volume is the blue line. So again, in this case, the superior border is the same, but the inferior border actually extends into the patient's groin area. So you do expose more of the patient to the imaging dose than the treated volume by the mere fact that you're limited by number of cassettes that you have, an Elekta unit, and by settings on your variant unit, the blade settings on that. And then next topic, inhomogeneity of imaging dose. And this actually, the question was raised before, what are those doses for? And this may answer that question. The imaging dose is not homogeneous. Like megavoltage portal imaging, it is kind of homogeneous. It's a semi-homogeneous dose distribution. Kilovoltage radiography, because of the rapid drop of the dose, is very inhomogeneous through the patient body. And kilovoltage combine, again, is non-homogeneous. Again, these gantry rotation angles, and there is increased dose absorption in the bone because of the photoelectric effect in that energy range. So megavoltage portal imaging is an image showing the anterior and right portal images, essentially 2 MU each. And again, this is what imaging dose would look like for that patient. Again, there is some, obviously, there is some dose inhomogeneity, but not a huge one. On the same token, if we use the 100, this one is orthogonal KV radiographs. I'm not sure what energy they simulated. It probably is 110 is the chest image. So again, anterior and right. And again, you can see the majority of the dose is deposited in this region because that's where the dose drop off is very quick. It actually drops to almost nothing on the exit side of the imaging beam. Kilovoltage cone beam, again, if it's a full arc, is different than a half arc or partial arc. But on top of that, we get increased absorption in the bone. So this is a Monte Carlo study done by Spezi. I believe it was some XPI unit, and it actually shows that enhanced dose absorption inside the rib cage, that's up to 10 centigrade. This is for one imaging session. So the soft tissue may get about 2, but the rib cage may get 10 centigrade on this side at least. And again, they show that enhanced absorption in the bone. So we need to keep this in mind when we use the kilovoltage cone beam, especially again, emphasize especially for the pediatric cases, because of the again, their bones have not grown, so they're in the growth phase, and this may potentially affect the bone growth if it's a high dose. And then kilovoltage versus megavoltage. So again, we can use 6 MV beam for this is what we've been doing for years, right? 6 MV beam for portal imaging. This is the anterior 6 MV beam. Is a simulation done by George Ding, and this is 110 kVp beam. Again, you can see the dose drop off is substantial for 110, and you can see dose to the sternum and to the vertebral body is higher because again, because of the enhanced absorption due to photoelectric effect. And this actually explains that this is a depth dose curve for 6 MV and for 120 kVp. It's very obvious if you go 20 cm deep with a 6 MV beam, your exit dose is about 40%. For 120 kVp is less than 10%. So again, very rapid dose drop off for the kilovoltage beams, and that makes a difference. So I talked about reducing imaging dose. Is that always a good practice? Should we do this? So reducing imaging dose is good practice if it is warranted for whatever reason that we may have, and it does not adversely affect the quality of the image. So this is very important. If your dose is reduced too much and the image quality is not adequate for proper patient positioning, then again, we defeat the purpose. We have to repeat the imaging, so we end up giving more dose to the patient. So because of that, again, image quality for the use must be adequate to patient positioning. I just mentioned that. Because of that, perhaps we shouldn't use reduction. We should probably use dose optimization. Reduction means we always reduce the dose. Optimization is you may reduce it, you may actually have to increase it. And I have an example of that coming up. So the more recent trend is to talk about the optimization of the dose and not merely reduction of the dose. I have examples of this. This is the work we did on this was a rando phantom. It's a phantom study. So what we did, we scanned, we imaged the rando phantom. This is the head and neck region with a standard head protocol coming with a variant true beam. And then we kept changing the different settings, number of frames, the MAS, KVP, and all that. So in the process, and we use the auto shift option on the true beam. So the true beam users know that I can do auto shift or auto match, they may call it, to basically adjust the patient position on the day of treatment to the original scan. So actually, we actually set this phantom wrong in a wrong position, and we allowed the unit to adjust the position of the phantom. And again, this is a rando phantom. So the only thing the software was using basically was bony anatomy. There's not a whole lot soft tissue contrast in that one. So we decreased the number of frames, and the auto shift didn't matter really. That's what she didn't care about the view. So it had enough information in that case to, again, shift the phantom to the correct position. As you can see, the differences are minimal. So, and this reduced the dose by about 55%. Again, this is a phantom study only. We did the same thing on the thorax portion of the random phantom. Again, same method, and we kept changing the different factors. And this example shows that you go, if you reduce the current time product by 2/3, again, the shifts are about the same, actually almost the same. And the dose reduction in this case was 67%. So when it comes to bony anatomy, reducing these, reducing the technique works, but again, bony anatomy. If you want to differentiate soft tissue, this may not work. A couple of examples from a colleague from Team Wood at UK. And this was actually a patient. So they had this young, slim patient. The default imaging technique is the one on the top they used. And then they changed the imaging technique. I think they did it 2 or 3 times, and they brought it down to 110 kbp 40 MA. So they reduced the dose by a factor of 3, but the image quality was adequate for the purpose. So in this case, it's an actual patient, and the dose reduction was justified. Another slide from Team Wood again. This was a very large patient. So the default imaging technique produced noisy images. So they actually had to increase the pulse width, hence the dose, to reduce the noise and improve soft tissue. So this is what I'm talking about optimization. You don't necessarily always have to reduce it. Sometimes you have to increase the dose because, again, your image quality is not adequate for patient positioning. So we have to go increase the dose in order to be able to set the patient correctly. So moving on to imaging dose calculation and estimation, AAPM TG180 recommends that the imaging dose be considered as part of a total dose if it is expected to exceed 5% of the prescribed therapeutic target dose. And there was a lot of discussion surrounding that, why 5%, and finally 5% was what we agreed upon. Because less than that basically is not practical, and we felt 5% is a good number because of the, again, for the ICIU recommendations on the 5% of the delivered dose must be within 5% of prescribed dose, essentially. So this report recommends 2 methods to estimate imaging dose. I'm not going to go into these because that TG180 is a whole different topic by itself. But they recommend 2 methods if it's more than 5%. One is a patient specific, that means compute the dose on the patient, which is very complex for KV imaging. You often need a Monte Carlo simulation, which I know not everybody has, so it's not really practical. The other one is a non-patient specific, which is essentially with a lookup table. And what we have in that TG report, we have a number of lookup tables for ovarian and Elekta units. We specify what KBP and MAS was used and all that, and it gives you an estimate of the representative organ dose to the patient. So again, there's a range in this because, again, patient size matters. But again, these are some of the organ doses you may get from this particular imaging. Again, we do have differentiation for the bone dose, for example, because absorption of dose in the bone is higher, of course, and the same for Elekta. So there's a number of these tables in TG180 as a reference to give an estimate of the patient dose. Similarly, was a report published in 2020 by the Children's Oncology Group, and there's a similar table in that guideline for the pediatric cases based on the age and what the dose to the patient may be. If anybody, by the way, needs, I'm not sure how accessible these 2 papers are, but if anybody needs them, please email me afterwards and I can send them to you. So we get to question number 2. I'm going to wait for Assad to have his poll ready. So imaging dose from kilovoltage cone-beam CT imaging. A is usually in the milligray range. B has a wide range due to protocols and dose inhomogeneity. C is higher than megavoltage cone-beam CT. Or D is similar in magnitude to kilovoltage digital radiography. I'm gonna give it another minute. Okay.
36% gives the first option, the 18% gives the second one, and 9% gives third one, and the last one is also 36%.
Yeah. So there is no consensus on this one. It may have been a bit of a vague question, I guess. So the answer is actually B. It is not in milligrade. I mean, again, it's a vague answer. I guess it could be milligrade or head and neck. I should change my question. So it ranges from less than centigrade to 2 or 3 centigrade. It is not higher than megavoltage cone beam. Megavoltage cone beam is the highest dose. It is not similar to KV digital radiography because KV digital radiography, you deliver a few frames. For a cone beam, you deliver 600-700 frames, so obviously you deliver more dose. So the B is an answer. It's a wide range. I think I had a slide said less than 1 centigrade to about 4 potentially, again, because there are different protocols, have different KVP and MAS units and different number of frames. So, and then the dosing homogeneity matters, different tissues. Okay, moving on to QA, last topic. So quality assurance of X-ray-based IGRT systems. So I've been looking for reports on this a while ago, and I found a number. Again, there is, as you expect, there's quite a few different national, international, regional organizations that have recommendations of this. So the ones on the left these are APM, these are American ones, this one, and that one. Lower left is a Canadian recommendation for IGRT. The middle one is British. And then on the right is the IAEA, and then top is it's a joint IFAMP ESTRO IAEA report on the QA of cone beam computed tomography. So this is I'm focusing on cone beam, mostly on the cone beam CT kilovoltage. So now if you look at those reports, there's often similar guidelines for routine QA. So as you expect, I mean, that's good. There's similar guidelines for QA, for EPI proton imaging, for planar kilovoltage, and for kilovoltage CBCT. And these reports usually don't deal with a specialized unit. So like if you have a tomotherapy or Radixac or CyberKnife, they have different reports that actually specify the QA guidelines for those. So here I'm comparing the APM TG179 recommendation to the IFAMP ESTRO IAEA protocol. So this one to that one. And I mentioned they are very similar. This one is quite older, actually. It's 2012. This one is 2019. So if you list the different, again, QA recommendations, and this is, again, you know, these reports are recommendations, and again, the different countries may have different guidelines or mandates. So, but these are recommendations. Like in the US, we follow recommendations, but these are not mandates. Mandates are set by the states usually. So, if we look at this on the top, there is items which on the TG179. Again, these are geometric accuracy, geometric precision. So the verbiage is different, but it's the same thing. So that the first group is a geometry. Next is the image quality tests. Next one is the image dose. And then the last group is the other QA tasks, the image registration, accuracy of remote controlled couch. So these are related to IGRT, obviously, but they are not, let's say they're not physical tests of the unit, of the integrity of a unit. So I go through these main ones, geometric accuracy. So the geometric accuracy is to ensure that the positioning of the movable components is spatially reproducible. I mean, you rotate the gantry, you bring the imaging arm, you extend it or retract it or the imaging panel and all that. Essentially, they go to the same place every time. So that's one thing. And also, you want to make sure the relative spatial relationship of the image structure is reflected in the image. So if you use the 10 cm on the phantom, it actually reconstructs at 10 cm. So again, the first part, reproducible positioning, you want to, again, make sure that you're on a daily basis, your kilovoltage, like on a cone beam CT, you want to make sure that the arms extend to the same place, the treatment and imaging isocenter coincides, and so on and so forth. So this is very common to use on the left-hand side, there is one commercial product. There's more than one, obviously. This is one example of them, the Quasar Phantom. Again, this is something that the therapists do, at least in the US. Therapists actually set it up every morning at the offset position, and then they image it, and then they shift it back to the auto shift function, and then they move the couch back to the true ISO center and make sure it is moved back. So they make sure that the imaging and the mega voltage beam lines are, again, they're isocentric, and the couch movement is accurate. On the right, I have two other tests. These are all variations of the Winston-Lotz test that everybody is familiar with. That was developed for thoracic surgery decades ago, I guess. So these are variations of that. These two are two products that are actually on the IsoCal Phantom actually comes with a variant Linux, variant Rubin Linux, and ball bearing Phantom comes with the Nectar Linux. Again, it's the same. They do it differently, but they do the same thing. They actually, again, check the geometry of the system. And usually recommendation is to do this on a monthly basis. And this is what a physicist does. On the left, at least here, we have the therapist do this part, and physics does it monthly. Linearity, again, you can scan a phantom, and if you know a known distance, you can, again, on a reconstructed image, you can measure that distance to make sure it's correct. So CAT phantoms are very common in the US. This is one example of them, CAT 504. Has different modules in it. So each one has a different task. So this module, which is a 404, it has that linearity points. It has essentially has these cylinders that are 5 cm apart, and you scan it and you make a measurement on the unit console and make sure it's 5 cm or within a millimeter or so. Low contrast resolution, again, ability to detect subtle differences in grayscale value. This is important for soft tissue visualization, which we often need to do for image guidance. Again, this is the same phantom, different module, and it's very hard to see, but there are actually low contrast circles in here. And this is a screen capture. It doesn't show very well. Usually it's better than this on the console. So we basically get a number of the circuits that we can detect and record those. High contrast resolution is a line per square millimeter. Again, line per millimeter, line per centimeter. Again, this is very obvious, and you can see it here. These are essentially, if any of you have done a diagnostic imaging QA, you're more familiar with this than us therapy guys. Uniformity and noise. Again, uniformity is a measure of the cone beam CT's ability to produce a uniform homogeneous object in different regions of a phantom, and the noise is fluctuation in pixel values. And again, we have a homogeneous section in this phantom. You drop circles in it, and you look at the average and the standard deviation to assess that. And the CT number density value, this is important when you use it for adaptive planning. As you are aware, many factors affect this: scatter radiation, beam hardening, if it's a high density material. Essentially, this is a monthly test to make sure the CT numbers for different plugs are the same. I only circle 3 of them, there's more than 3 in here. So how do you evaluate and quantify this? So those are the tasks that we do, but how do we quantify this, how to evaluate this? Like geometric ones have a specific tolerances. So the MVKV beam isocenter coincidence, so let's say 1 millimeter. The image quality tests have no tolerance value. So all the recommendations say, okay, do this on a monthly basis and compare that to the baseline one. So this becomes a bit vague. So AAPM TG179 specifies that the test be performed during system acceptance to get your baseline. Again, that's your acceptance and commissioning task. APM Medical Physics Practice Guideline 2A again says to baseline value refers to IGRT system manufacturer's minimum performance standard. So there is very similar but slightly different. So establishing baseline has been subject of some work. I just have a paper here by was published in 2020 And then they evaluated this, and the conclusion was, okay, you need to establish this baseline pair imager. So you cannot have, if you have more than one true beam, you should do it for each one of them, even if they're the same model. And then they say you may have to reestablish them after imager calibration. Now, I show you those. How do we evaluate this? Do we do visually? Do you use a software? But if you don't have a software, so again, this is a study that we did. This actually is not is more data than this, and it will be published soon. And we compared the visual, like I search for those circles as opposed to essentially send the image to a software. In this case, we use a read software, and see if a difference. And again, there's differences between different observers too. And so what we concluded was that if you do visually or do software-based, there is a statistical significant differences for some, but not all the modules. So like a Huntsville unit didn't matter really if you do it visually, do it manually, or do it via software. But the low contrast resolution did matter if you do it with a software. And then when it comes to that automatic QA, this is a paper that was published by a group from UCSD in 2019. And they actually did automatic QA using, again, same Phantom, and they used some commercial product, ImageAll, total QA. And they did 23 image quality issues, 18 were discovered by therapists. And the automated QA, and they concluded when running through that automatic QA, it may not predict all the human observable images. So oftentimes, the software may not catch it, but a physician looking at the image may detect something. And I've had this experience myself, that a physician looks at the image and says, oh, something doesn't look right. And then we discover something wrong with the image. And this was an older LINAC. So automated QA may be usable. I mean, it is probably a good idea, but it may not catch everything. So I think we still have, for the foreseeable future, use some manual intervention doing QA on this. And then image dose. Image dose, this is different than a patient dose. This is different. Image dose, when in these reports, they refer to the output of the unit, not a patient dose per se. So many reports from APM, they actually recommend measuring this cone beam CT dose on an annual basis and compare it to baseline values. And none of them say how to do it, but they say do it. So it's up to us to decide how to do it. And many have employed the CTDI concept that has been around for a long time, since the 80s, for the CT scan output assessment. And it has been employed for cone beam CT. It can be used as a constancy measure, but it suffers from inaccuracies. There is a finite phantom and detector length, there is a half beam scanning, etc. So the CTDI used in cone beam CT is a subject of a whole presentation by itself. The other methods to do that, there's the IAEA report 5, human health report number 5 methodology, which is again based on CTDI. There is a APM TG111 report, which is totally different. Or there is something that we do. We actually use a farmer type chamber that we have in the clinic, and we essentially make an error measurement. I mean, the chamber has to be calibrated for kV beam energy, of course, but we make an error measurement similar to measuring a sub-C measurement, and we essentially look at the constancy of value. And I can tell you, I've been doing it on our R2 beam for 7-8 years, and it's very constant. Actually, it doesn't change by a whole lot. So that brings me to last question. I give a sudden moment here. So quality assurance of cone beam CT systems, includes monthly image quality checks. B includes monthly imaging dose assessment. C can be fully automated. And D varies widely based on national and international guidelines. Okay, well, I have 5 more seconds, I guess. Yeah. Okay, so 55% monthly image quality checks and 45% varies widely. So the correct answer is A, monthly image quality check. The imaging dose is annual, cannot be fully automated. So question D, maybe I should change my wrong answer. So again, I mentioned before, I compared the EFUMP IAEA1 to TG179. And actually, they're very similar. They call them differently. So in effect, if you look deeply into them, they're very similar. So they vary slightly, but not widely. Again, my answer is probably a bit subjective. It's not clear. Okay, very good. So that's moving on to summary. So in summary, the image guidance has evolved again from interfraction to intrafraction monitoring. I mentioned the CyberKnife, the MR Linac, and all that. Those are actually capable of doing intrafraction monitoring. And again, we have this advancement has been along with the advancements in beam modulation. And again, often includes multimodality imaging. I mentioned X-ray base here only, but oftentimes you have surface imaging plus from infrared markers potentially and X-ray imaging combined multimodality imaging. So they need the patient, position the patient accurately, again, due to decreased margins and to monitor target movements has become critically important. The previous speaker alluded to that again, the bladder filling, the rectal filling, all of them differ every day. So it's very important. And again, we use smaller margins this day with the DMAT and IMRT. So it's very important to monitor that. So we need to have a robust IGRT system. X-ray based imaging will continue to play a role in IGRT. There are other non-X-ray based ones too, but we probably will be using X-ray for a while to come. It does deliver additional dose to the patient. Megavoltage 3D imaging delivers the highest, kilovoltage 2D imaging delivers the lowest. And imaging dose reduction or optimization may be necessary in certain situations. Quality assurance is governed by, again, similar national, regional, international guidelines. It requires basic knowledge of imaging physics. That, again, that's something that, at least in the US, the imaging physics, therapy physicists do not do imaging usually. So again, they have to gain that knowledge. And the IGRT involves, again, more than imaging system QA. It ties in with the other QA tasks. I mentioned the image registration QA or the couch movement QA and so on and so forth. So it's part of the comprehensive QA regimen of a Linac. And that does it. And thank you for your attention. Any questions, I'll be happy to answer.
Participant can unmute themselves to ask the questions, or you can write the questions on chat box. Okay, I have a question, sir.
Sure.
Can we use ionization chamber for the dose measurement for the CBCT?
Yes, we do. Actually, we do that.
Specific ionization chamber?
We do actually use a farmer type chamber. So, but we have to calibrate that for the KV imaging dose. So in the US, we can do that. I don't know how it works outside the US. I know there are IAEA calibration labs, correct? That you can send your chamber. So we actually send it for calibration for like 150 kVp beam in order to get the n sub k from them and get accurate dose. Now you can actually, if you're doing constancy measurements, you can actually measure the ionization, don't convert to dose at all, and use that. And probably satisfy some of them.
So as you have mentioned that in US there is a specific imaging physicist. So do the QA of the CBCT or the therapeutic physicists do the QA?
No, the therapy physicists do that actually.
Okay. So
yeah, we don't. For CTs they do. For the COM CT we do it ourselves actually. We don't. For CT scanners actually state regulations that certain things have to be measured and you're not equipped to do that. For cone beam, there is none. So for cone beam, basically follow what I showed you, and therapy physicists do that.
Is there any legal requirement to report the imaging dose for the treatment?
No.
Okay.
No, there's no requirement.
There is a question in the chat box. What about the silicon diode? Epitaxial silicon diode.
Yeah, so silicon diodes have a high energy dependence on the low energy, right? Because of the silicon. So your reading is not going to be accurate. But I mean, again, for constancy, you can do it, yes. But you won't get accurate dose from that because of increased absorption. The silicon, I mean, there is a high Z material, correct? So yeah, your dose might not be correct, but for constancy, you can use any detector you wish. There's a question about impact of calibration on the true beam system. If by calibration you mean the output adjustment, no. There's nothing affects the image quality unless something happens to the KV X-ray tube. It's changed or the panel is replaced or things of that nature.
Another question I have, in TrueBeam, there are specific calibration tests for the imaging devices. It has a timeline like 30 days, or we can set to 60 days, something like that. So set of imaging tests, like machine specific test. So is there any background of that test? Because we run blindly, just click, follow the guidelines without knowing what is happening.
So interesting. I have not done that. So there is a, as part of the preventive maintenance, our service engineer does some of that. But again, do you have a newer TrueBeam unit?
Yes, we have.
Yeah, so I know there is a, what do you call that? So I have not actually done it myself on our TrueBeam. We have a bit of older one. And I forgot what they call it actually, that test, but thanks for bringing it up. I have to look into that now.
You have mentioned that there are certain acceptance tests done. During the acceptance, there is a baseline test was done along with the engineers, and
right, yeah,
a recommendation of WPM that we have to follow those baselines, right. And that's what we performing on the machines.
Okay, so you're following the manufacturer guidelines, so you must be doing yeah. But I mean, you don't change anything, right?
Yes, we are not changing. We're just running the test. Okay,
so thank you. On the test.
Thank you very much, sir, of your time. And
no problem.
We are quite grateful, or participants are quite grateful that you have shared your valuable time with us. It's morning in the US. It's early morning.
Yeah, so, well, it's okay. It's 7 a.m. now. So
okay. So thank you very much, sir. Last question is there. Is it possible to incorporate the imaging dose in PTS?
In the TPS. So yes, so that's what I did a while ago. I did it with some inaccuracies. And for kilovoltage at this point, no, because none of the planning systems are capable of calculating those in the kilovoltage range. So it's not.